Department of Pathology. She's also a professor of the Duke National University of Singapore. And she has published many papers, and I'm hoping that she can present all this knowledge to us. And this is... So,
causes and pathogenesis, we've heard earlier: environmental, genetic, epithelial polyps, inflammatory bowel disease, and irradiation, for instance, in patients who have irradiation for previous cervical cancers. So I'll dive straight into the gross pathology of colorectal cancers. About 50% of the cancers occur in the rectosigmoid area, and there has been an apparent shift to the proximal colon in recent decades. Right-sided cancers tend to be more frequent in the elderly, in the black population, and in patients with diverticular disease. Multicentricity is detected in between 3 to 6% of cases, and macroscopically, colorectal cancers can be polypoidal, ulcerative, and fungating. There is a good correlation between the gross and microscopic tumor margins. Cut sections show grayish-white appearances. Mucinous tumors are gelatinous and glary. And as a pathologist, there are important gross features to note when we are handling a colectomy specimen, namely the depth of invasion of the wall of the bowel, the presence, if any, of vascular invasion, and this is probably more well detected on microscopy, and a look and evaluation at the appearance of the rest of the colon or rectum. So this is a part of a colectomy specimen, and you can appreciate a relatively ulcerated and slightly fungating tumor that occupies the entire circumference of the bowel wall. And in this example, you have a polypoidal mushroom-like tumor that protrudes into the lumen of the colon. And in this example, you have a tumor that is centrally ulcerated with rolled edges that occupies part of the wall of the large bowel. And this is a slice through the tumor. And here you will notice the whitish-gray appearance of the tumor, and it invades through the entire colonic wall into the pericolic fat. And in this particular picture over here, you can see that the tumor has only extended into the muscularis propria. So it's important for pathologists to slice through the tumor carefully and to determine the deepest extent or depth of invasion, as if you did not slice through this portion, you might just erroneously conclude that the tumor invasion is only into the muscularis propria, whereas in fact it has gone out of the bowel wall into the pericolic fat. Microscopically, most colorectal carcinomas tend to be well to moderately differentiated adenocarcinomas. There can be a stromal reaction with variable lymphocytic infiltrates. The tumor surface may be papillary or villous, and as mentioned earlier, it can invade into all layers of the bowel, and perineural as well as lymphovascular invasion can also be seen. So this is a typical appearance of a moderately differentiated adenocarcinoma of the colon, in which we have confluent glands and some papillary structures that are formed by cells with stratified hyperchromatic nuclei and with brisk mitotic activity, and this is seen within a desmoplastic stromal reaction with accompanying inflammation. Here we have a full thickness section of the bowel wall, and you can notice that the tumor extends throughout the bowel from the submucosa over here, effacing the muscularis propria and extending into the pericolic fat that invokes a desmoplastic fibrous reaction. And this is a nerve in which there is intraneural invasion by malignant glands, and this is lymphovascular invasion, in which there are tumor cells represented by these signet ring cells lying within a lymphovascular space. In terms of histochemistry and immunohistochemistry, most colorectal adenocarcinomas will demonstrate mucin positivity using the mucicarmine histochemical stain. Additionally, on immunohistochemistry, there can be the positive reaction for these antibodies to antigens of MUC1, MUC3, MUC2, and MUC1-3. Immunohistochemistry, there is usually a profile of cytokeratin 20 positivity and cytokeratin 7 negativity in colorectal cancers. And this is very useful in terms of distinguishing it from lung or ovarian cancers, which show an opposite profile. In other words, lung and ovarian cancers will be cytokeratin negative and cytokeratin 20 negative and cytokeratin 7 positive. There is also positive reactivity in colorectal cancers for CEA, CDX2, as well as vilin. So this is an example of an adenocarcinoma that was detected in a lung biopsy, and we concluded that it was a metastatic colorectal carcinoma to the lung, not only because of its morphological appearances that resemble a primary colorectal carcinoma, but also because of the immunohistochemical support that we got with CDX positivity diffusely in the nuclei of the tumor cells and the TTF1 or thyroid transcription factor 1 negativity within the tumor cells. And here you can see the internal positive control of the alveolar lining cells of the lung, as opposed to the negative staining of the tumor cells of the metastasis of the colorectal carcinoma. Molecular genetics has become very important in colorectal carcinoma, and we have discovered the genetic alterations that drive carcinogenesis. And earlier we heard from Dr. Tant about the APC and the mismatch repair genes, which are also mutations responsible for the sporadic colorectal carcinomas. Just a few words about the DNA mismatch repair deficiencies that result in microsatellite instability. It constitutes about 15% of the cases, and it's usually associated with the hereditary non-polyposis colorectal cancers, right-sided in location, cancers arising from serrated polyps. And these cancers pathologically tend to be mucinous, poorly differentiated, have a prominent host response, have circumscribed growth patterns, and be right-sided. And this is what we immunohistochemically see as a pathologist when we carry out immunostains for the DNA mismatch repair proteins. So this is MLH1, and you can see the tumor over here showing positive nuclear staining for MLH1. This is MSH2, which also demonstrates positive nuclear staining in the tumor. MSH6, similarly with positive staining, and PMS2 with nuclear staining of the colorectal cancer, indicating that there is no abnormality in these DNA mismatch repair proteins. Other mutations in the BRAF, the PIK3, and the beta-catenin genes. And there are also mutations in tumor suppressor genes for P53, APC, and these variety of other genes as well. From the pathologist's point of view, apart from the usual adenocarcinomas that we encounter, there can be other microscopic types such as mucinous, cygnet, micropapillary, basaloid clear cell, and so on. So there's a host of different microscopic patterns, but they tend to be much rarer than the usual conventional adenocarcinomas that we encounter. So this is just an example of one of the less frequently encountered subtypes of colorectal cancer, and this is a signet ring adenocarcinoma, and you know why it's called signet ring, because of the appearance of the cells showing this peripherally compressed nuclei and this cytoplasmic vacuole or mucin that pushes the nucleus to its side. The diagnosis of a colorectal carcinoma is accomplished using a biopsy, and a biopsy that is positive should always be obtained prior to radical surgery for colorectal cancer. These biopsies are obtained from multiple areas, particularly in large lesions, so that you get a better representation. And it's always very important to have close communication between the pathologist, the endoscopist, and the surgeon. In other words, it's a multidisciplinary type of effort to make the diagnosis as well as to treat the colorectal cancers. And an intact biopsy of adequate size and depth with proper orientation of the specimen is very important. So just a few words about staging. Staging of colorectal cancers have evolved over the years. It started off with a Duke system, which is three-tiered, A, B, C, in 1937. Later on, there was the Essler and Collar system in 1954, but now the AJCC-UICC system with a T and M classification is the most widely adopted. So here we have the TMM staging for colorectal carcinoma, and just to look at the T stage over here, TIS is when the tumor is confined to the mucosa, carcinoma in situ. T1 into the submucosa, T2 the muscularis propria, T3 into the subserosa, and T4 when it perforates the peritoneum or attaches or invades adjacent organs, and N0 is when there is no nodal metastasis.
To the next speaker. Next speaker is Dr. Michael Chody. He's a very good friend of mine that we knew since he was at his tenure at the Hopkins. He is now the Chief of Department of Surgery, a Division of Surgical Oncology at University of Texas, Southwestern Medical Center. And he is a well-known GI surgeon. His experience in pancreatic cancer and liver cancer has been really renowned all over the world. He has published many papers, and I'm glad that I'm really excited that he is willing to come and give a talk here. So, Dr. Chody, please come up to the podium. Thank you. You still have to use that, right?
We're using this microphone? Okay. So I'd like to thank all of you. We're going to focus now on continuing the theme of colorectal cancer with the surgical management. Again, I'd like to thank Dr. Mio Thant and the organizers and the wonderful hosts for our visit here, and to thank ASCO for hosting this outstanding program. So here are my disclosures. So first, as we heard about, colorectal cancer is a big problem. It's one of the most common malignancies worldwide. In the U.S., you can see the third most common cancer in men, second in women, and worldwide the incidence is going up. You heard about, we don't know if it's the Western diet or whatnot, but in many developing countries, as liver cancer and head and neck cancer, cervical cancer is going down, the topics we're going to be hearing about breast cancer, in particular colorectal cancer, the incidence and is going up. Here you can see some data from Southeast Asia, and it's interesting. Colorectal cancer is extremely common. If you look at the incidence and the mortality, lung cancer, liver cancer, and colorectal cancer among the most common. So you can see in men, you've heard about third leading mortality. But because it involves both men and women, overall, it's an extremely common malignancy. As you also heard, it's very preventative. So this is an area where education and multidisciplinary management is important. Here's some data in Southeast Asia. You can see, of course, Myanmar here. Look at some of the GI cancers, oral, esophagus, liver, and so forth. So you can see the incidence of esophageal cancer quite high, liver cancer high, but you can see here, compared to even Thailand, the incidence actually of colorectal cancer is slightly less in Myanmar compared to the other regional countries in this area based on the incidence per 100,000. This is in data for males, but similarly in women. So again, common malignancy. I'm going to focus briefly on an overview of the surgical management, arguably the real mainstay of treatment, really the only curative option, surgical management. So we'll talk about treatment of primary colon cancer, rectal cancer, and even the surgical management of metastatic disease. I don't need to share with this audience the anatomy of the colon and rectum. It's really the large intestine. So the last meter or so of the intestines is the large intestine, the right colon, transverse, descending colon, and the transition to the rectum. The distinction between the rectum and the colon is really more, one is an intra-abdominal structure and one is a pelvic structure. But really, biologically, they're very similar. You'll hear about the treatments are different. The surgical management of rectal cancer is more complicated. The recurrence in the pelvis can be an issue, so that radiation therapy and surgical techniques are very important, in particular with rectal cancer, but also with colon cancer, it's important. You've heard already about staging. Colon cancer starts as premalignant polyps in the lining of the mucosa, and as the penetration through the wall of the colon increases, the stage, the T stage, and then spread to lymph nodes, and then stage 4 is metastatic spread. So the idea is earlier detection through the screening methods you heard about is the really way to impact the disease. It's not chemotherapy or even fancier operations. Earlier detection is really the best way to even prevent the disease. Let's talk about management of primary colon cancer. The principles are pretty clear. Removal of the primary tumor with clear margins, lymphadenectomy, that is removal of the regional lymph nodes, and restoration of the organ integrity. So you heard a little bit about the importance of the lymphadenectomy. It's not so much a therapeutic, although that's part of it, it's important for staging. So again, the importance of the lymphadenectomy is both the surgeon's role to do a sufficient lymph node removal, but also it's particularly the pathologist's role to adequately assess the specimen to determine the number of lymph nodes, because that serves as the denominator, if you will. And lymphadenectomies, or lymph node assessment, in which the amount of lymph nodes are assessed is limited, can result in worse outcomes. So this is a very important concept. When one thinks about the surgical management with regard to the lymphadenectomy, this is, of course, the colon. The lymph nodes follow the arterial drainage. So that's why with cancers of the right colon is removed in order to remove the lymph nodes along the lymphatics, along the arterial blood supply. So an adequate resection of the right colon involves removal all the way to the origin of the right colic artery and so forth around. So the concept is pretty straightforward in the surgical removal. So when one thinks of the colon operations, that's why we think these are the typical ones. So if the cancer is in the right colon, right hemicolectomy. Again, the reason so much colon is removed, and it's not so much, but this portion is because this is the lymphatic drainage that necessitates removal of this part of the colon. And then the connection is done between the ileum and the transverse colon. Similarly, left colon cancer, left hemicolectomy. So that's the fairly straightforward. One area is the role of laparoscopic colon resection. And in fact, this is a study, a randomized trial published in the U.S. comparing open to laparoscopic colon surgery. And basically the data shows that oncologically the operation is the same. The number of lymph nodes removed is the same. The complication rates are the same. Somewhat less of a length of stay. So at least in the U.S. and I think worldwide, laparoscopic colon surgery or open colon surgery is equivalent. And I think it depends on the expertise of the surgical team. But more and more, I would say in the U.S., about 2/3 of straightforward colon resections are now done laparoscopically. What about rectal cancer? More complicated surgically because of the proximity to the anal area, and also more important to have really a multidisciplinary approach to rectal cancer. Again, the anatomy is important. So rectal cancer is defined as the last 12 centimeters from the anal verge. The distinction between colon and rectum, increasing local recurrence, use of radiation therapy, the use of neoadjuvant. In colon cancer, we typically do the surgery first and then adjuvant therapy after. In rectal cancer, we'll more often do neoadjuvant radiation and chemotherapy prior to surgery. Very important is the sphincter preservation and the concerns about urinary and sexual dysfunction that make the operations more complex. The names of the surgical operations for rectal cancer are a little different. We typically use the term low anterior resection to mean removal of the rectum and preservation of the anal area with a low reconnection or a coloanal reconnection. So this is called the low anterior resection, and this is the most common operation for rectal cancer. When the cancer is very low, very, very low, involving the anus, then a permanent colostomy is required, so-called abdominoperineal resection. It used to be that in rectal cancer, even 20 years ago, this was the most common operation. Everyone with rectal cancer, APR, abdominoperineal resection. Now with more modern techniques, we'll talk about, only about 1 out of 20 rectal cancers need this operation. Only extremely low cancers. So we've made major advances in the reduction of the need for colostomy in patients with rectal cancer compared to even decades ago. And this is a very important principle because, of course, patients are very afraid to come to treatment for rectal cancer because they're afraid they're going to have a colostomy. And so it's rare now that we need to do a colostomy. And we'll talk about some of the reasons. And these are the ways we've made progress in the reduction of permanent colostomy. One is very important are the surgical techniques. So there are now stapling devices and methods to do the reconstruction very, very low near the anal sphincter, where in the past it was more challenging to do that. Stapled it, coloanal reconstruction, and local resection in selected cases, transanal removal of early cancers. But also the use of preoperative neoadjuvant chemoradiation therapy can now shrink the cancer that may be against the sphincter and thus allow the ability to remove it with preservation of the anal sphincter. So preoperative chemoradiation therapy has contributed to the reduction in colostomy, as well as improved staging. So with endorectal ultrasound and pelvic MRI scans now, we're better at staging the depth of penetration and thus determine which patients may need neoadjuvant therapy or not. The other important concept in the surgical management of rectal cancer is the adequate wide removal, so-called total mesorectal excision. In the past, there was a lot of surgeons stayed very close to the cancer because they were afraid of damaging the nerves of bladder function, for example, resulting in a high incidence of local recurrence. Where now we understand that a wide, sharp dissection around the cancer to remove the full envelope of lymph nodes significantly reduces the local recurrence rate. So this is a specimen showing the fatty pad around the rectum. So it's not the distal margin that's important, it's the wide removal. In fact, if you look at the old data of the role of radiation therapy, it was often based in surgical techniques that had a very high local recurrence. If you look at the trials, the old NSABP R01, the benefit of radiation therapy in reduction of local recurrence reduced the local recurrence from, let's say, 25% all the way down to 15%, dramatic benefit of radiation therapy. But now the surgical techniques are so much better that we are seeing local recurrence even without radiation therapy in the single digits. So some of you have questioned the role of radiation in the face of improved surgical techniques, at least for the reduction of local recurrence. So very important concept of important surgical techniques to improve outcomes in patients with rectal cancer. One point about, there are also ongoing trials now of laparoscopic rectal surgery versus open rectal surgery. This is a trial ongoing now through a cooperative group in the U.S., more controversial as to whether laparoscopic low anterior resection, for example, is comparable to open surgery. But I think depending on the center, some are doing laparoscopic and some are doing open for rectal surgery. So when one talks about the role of chemotherapy, and you'll hear more about this shortly, very important, we use chemotherapy, as I mentioned, in the neoadjuvant setting for rectal cancer, in the adjuvant setting after surgery for colorectal cancer, and of course for advanced disease. When one thinks about the treatment of colon surgery, as I mentioned, typically in most cases, surgery is done first and adjuvant therapy is given after, typically only chemotherapy without radiation therapy, where in rectal cancer, more common at least for stage 2 or stage 3, neoadjuvant chemoradiation with radiation therapy, then surgery, and then more adjuvant chemotherapy. And we'll hear more in more detail in a moment. Finally, let's talk about metastatic disease and the role of surgery. Another important area where we've made significant advances, and I think it's very important to educate the medical community, including the role of surgical therapy for metastatic disease. You'll hear about, we've had significant advances in the role of chemotherapy for advanced disease, with response rates that are now becoming significantly higher and median survivals, even with chemotherapy, that are in the range of more than 2 years. But in patients particularly with limited oligometastatic disease, particularly to the liver, surgical therapy of the liver is something that's being done with increasing frequency with added benefit. So about a third or more of patients with a liver-only metastases, and these patients we should also always consider, when possible, surgical therapy of the metastatic disease. Here's a case of a patient with metastases to the right hemiliver, right lobe of the liver. This is a patient that actually received preoperative chemotherapy and then underwent successful surgical therapy of the metastases in the liver. So it's an area, and many patients, as you'll see, these are the survival rates of metastatic colorectal cancer. If surgery is an option, complete resection, we're seeing 5-year survival rates, even in this older series from Germany, reporting in the 35 to 40% 5-year survival rates. If you look at the more modern series, in fact, we published a decade or more ago, but modern series are now showing 5-year survival rates more than 50%. So arguably better than many primary GI cancers with metastatic disease, in which we're often using chemotherapy combined with surgical therapy of the metastatic disease. One important point in the management of the metastatic disease in the liver is defining resectability. And this can often be difficult. It's really we define it by the location of the metastases relative to the structures within the liver, so that we can get adequate remaining liver. And so this necessitates high quality imaging of the liver, CT scan and MRI scan in selected cases, to assess the relationship of the metastasis to the structure within the liver. And in some cases, PET scan is important to assess, and often even 3D rendering or volume analysis to determine the remaining liver, in order to determine if a patient may have resectable metastases in the liver. In fact, we've become much more aggressive. These are data from Johns Hopkins showing that in the older series, most patients had solitary single metastases you resected. Here you can see 50% had one, and very rare did we remove multiple. Now we're seeing patients 5 or more metastases, or half the patients have 3 or 4 or more metastases. So more and more aggressive now in patients even with multiple metastases. The role of chemotherapy is very important in integration of the metastatic and potentially surgical patient with metastatic disease. And we often will think, so if we think of liver metastases either resectable or unresectable, we will integrate chemotherapy in the resectable patients either before or after removal of the metastatic disease. And in some cases, we call this neoadjuvant or adjuvant, and in some cases we'll even use chemotherapy in the patient that's unresectable to shrink the cancer and make them now operable. An interesting concept that in fact occurs on occasion. This is a patient you can see with a large metastasis in the right liver, but it's involving the veins here and involving the left structures, unresectable. Chemotherapy, preoperative, conversion, shrinking the cancer, now the tumor is operable. So this is a strategy we'll use in selected cases as well. And this downsizing concept in situations. And then there are other approaches we can do to increase the eligibility. I mentioned we can downsize with chemotherapy. We can also use local regional therapy to downsize. And sometimes we'll grow the remaining liver through stage resections, 2 operations to remove the cancer in the liver, for example. Or sometimes ablation, heat, a microwave or tumor ablation in cases when the cancer is not removable. What are some of the surgical advances? Well, there are a lot of advances surgically. More and more, at least in the US and worldwide, minimally invasive and robotic surgery is done selectively, new imaging tools for both the liver and the colon, and newer devices are being used to be able to more safely do these operations. So the mortality rate now of even major liver surgery for colorectal metastasis is less than 1%. So we've improved significantly in these. Finally, just to touch on the importance of the complexity of the multidisciplinary care, particularly in the stage 4 patient. If one thinks about making treatment decisions, how would you manage this? Very straightforward. Primary colon cancer in the sigmoid colon. This is a patient with 2 metastases in the right liver. It looks resectable. Easy, right? How would you manage this straightforward procedure? Synchronous resectable disease. Well, the options, we can do the colon, then the liver, then chemotherapy. We can start with chemotherapy, then the colon, then the liver, then more chemotherapy. We can do this way with chemotherapy in between. We can actually do the colon and the liver together. We can do this way. And with even sometimes we may do the liver prior to the colon. And with rectal cancer, forget it. We're off the map here with so many choices. So as you know, with many of the oncologists here we work with, it requires communication and a team, not a vertical management, but really thinking about the team optimizing the best strategy for the patient with a goal, optimizing the cure and maximizing the quality of life of the patient. So in summary, surgical management of colorectal cancer, it's complex, but it's very important. It's a common disease, but a major health problem. Surgery is the primary therapy if it's localized. Surgical advances we've talked about, adjuvant and neoadjuvant we've talked about. Aggressive surgical therapy of metastatic disease is improving the survival in these patients. And the key is the multidisciplinary management, early staging, imaging, and combination therapy to really improve the outcomes of our patients. I thank you very much for your time.
Thank you, Dr. Chody. Next speaker will be Dr. Barrowell. He is the Associate Professor of Radiation Oncology at University of Pittsburgh Medical School Center. And again, he has published many papers, and I'm excited that he is willing to come and give us a talk about the radiation therapy in colorectal cancer.
Okay. So, as mentioned by the previous speaker, the role of radiation therapy in colorectal cancer is mainly limited to rectal cancer. There is very limited role of radiation therapy for colon cancer. So my discussion would be mainly for the rectal cancer. So the local recurrence after surgery for rectal cancer for T3 to 4 disease could vary from 15% to 30%. And the reason why the range is because the surgical advancements that significantly reduce the risk of local recurrence. In the past, the risk of local recurrence used to be more close to 30%, but in the era of TME for T3, T4 disease is more close to 15 to 20%. Following surgery, radiation alone improves local regional control, but doesn't impact overall survival. And chemotherapy was initially investigated to see whether we can improve the outcome or not. So some of the earlier data came from the cooperative group where they compared post-op radiation therapy to post-op chemoradiation therapy, both in concurrent and sequential setting. And as you can see, the addition of chemotherapy improved local control, decreased distant mets, and improved survival, thereby establishing chemotherapy as part of the treatment for colorectal cancer, with the addition of radiation therapy improving local control. After the publication of that trial, the standard treatment for post-op treatment for T3, T4, and positive rectal cancer was adjuvant chemotherapy, followed by chemoradiation therapy, followed by adjuvant chemotherapy. But if chemoradiation therapy is required post-op, maybe it is better given pre-op than post-op. The advantage of giving pre-op chemoradiation therapy is it downsizes the disease, so making sphincter sparing surgery possible. You need less dose of radiation therapy probably because there is non-hypoxic environment. You can sterilize the margin, which can improve the likelihood of local control. And the better tumor oxygenation may improve tumor response and may be better tolerated. Some of the earlier study which evaluated pre-operative radiation therapy was the Swedish rectal cancer trial, which was standard operation non-TME versus pre-op radiation therapy followed by the surgery. And what the clinical trials showed that by adding pre-op radiation therapy, we improve local control, improve overall survival, and improve cause-specific survival. This was the only clinical trial in pre-operative setting which showed improvement in survival. But again, the local recurrence rate were higher because the surgery was not TME, which is the standard of care nowadays for rectal cancer. So in the TME era, the first randomized clinical trial where the TME was evaluated in prospective way came from the Dutch group, where about 1,800 patients with T1 to T3 disease, they were randomized to TME surgery alone, and this TME was quality control where the surgeon had to get training done for the TME. They had to be mentored for the TME and to make sure the quality of the surgery was as required. And the other arm was pre-operative radiation therapy followed by surgery. And as you can see, the local recurrence went down significantly. In the previous trial, the local recurrence rate were more like 25 to 30%. In the TME era, the numbers were like 11%. Radiation did improve the local control rate, but the absolute difference was small. And there was no difference in overall survival. On subset analysis, they noticed that in stage 3 disease, the local recurrence rate, even with TME, was about 18%, which was brought down to less than 50% by adding radiation therapy. But again, radiation comes at a cost. There were more wound complication, more post-operative leaks requiring additional intervention. So the adjuvant trials demonstrated chemo-RT improves survival. If pre-operative radiation therapy is better than post-operative radiation therapy, and this question was answered by these two clinical trials. The MRC, which compared short course of pre-operative radiation therapy to selective post-op chemo-RT, and the German rectal trial, which basically established pre-operative chemoradiation therapy as standard of care in North America. So if you look at the MRC trial, what they did was, the one arm got pre-operative radiation therapy to 25 grain 5 fraction, followed by surgery. The other arm got TME surgery, followed by selective post-op chemo-RT only if the margin was positive. But they noticed that this selective approach of just limiting post-op radiation therapy to margin positive was not the optimal approach, because the local recurrence rate in that group was about 11%. And similarly, the disease-free survival was also inferior. The local recurrence rate in the pre-op group was only 4% with a better disease-free survival. There is no difference in overall survival. Thereby establishing that if you have to do treatment, pre-op is a better approach than post-op because of better local control and better disease-free survival. But the trial which basically established pre-op chemoradiation therapy as standard of care was the German rectal trial. It's a large trial of about 800 patients, T3, T4 disease, N positive. 2 arms. The first arm was the post-op arm where everybody got TME followed by chemoradiation therapy. You can see the dose of radiation therapy was about 10% higher in the post-op group, 55.8 versus 50.4. But adjuvant chemotherapy was very similar. And what the study showed that the local recurrence rate in the pre-op arm was significantly inferior, significantly better in comparison to post-op, 10% versus 7.1%. Number of patients in the pre-op arm who could have sphincter sparing surgery was significantly higher. There were about 50% improvement in sphincter sparing surgery, 20% in the pre-op group versus 39% in the post-op group. So another advantage of pre-op radiation therapy was downsizing, making disease suitable for sphincter sparing surgery. Look at the complication rate. There was both acute and the late complication was significantly less in the pre-operative group. The acute diarrhea, acute any grade 3 complication was significantly less in pre-operative group, 27 versus 40%. And if you look at the long-term complication, the most common one is the stricture formation. It was 3 times less in the pre-op group versus the post-op group. So the pre-op group had fewer acute complication, fewer late complication. The only downside of the pre-op treatment was over-treatment. As alluded that when you do this pre-op treatment, you use endoscopic ultrasound or pelvic MRI for staging, and about 15 to 20% of the people are overstaged, even though you think they are T3, T4 disease, but at surgery they are found to have T1, T2 disease. So one downside of pre-operative treatment is over-treatment for a subset of people. But the fact that the local control is better, there is more sphincter sparing surgery feasible, and less acute and chronic complication, all 4 advantages overcome the disadvantage of over-treatment. So the pre-operative treatment advantages: more compliance, lower acute and chronic side effects, better downstaging which makes sphincter sparing surgery feasible, and better local control. And the only downside is over-treatment. So based on these 4 or 5 potential advantages, this has been established as standard of care for neoadjuvant chemoradiation therapy for locally advanced rectal cancer. Now, we discussed about the pre-operative regimen. There are the two regimens which are used all across the world. One is 25 Gray and 5 fraction based on the Swedish data, or the protracted one, 45 to 50.4 Gray, with concurrent chemotherapy followed by surgery. The short course is more cost effective and more convenient to the patient, but the long course you can combine with chemo, so you can have more downsizing, you have better likelihood of sphincter preservation, and maybe better functional outcome because of conventional fractionation. The first randomized trial comparing the short course to the long course was from the Polish group, about 300 patients. The short course was pre-op 25 Gray and 5 fractions followed by surgery, and the long course was a standard 50.4 Gray with 5FU and leucovorin followed by surgery. And you can see the trial was, even though it was not powered to see the difference, they did not see any difference in local recurrence rate or overall survival, and noticed less acute toxicity with the short course of treatment. At the same time, a similar study was initiated by the TROP group, which again compared the similar regimen, pre-op 25 Gray and 5 fractions, followed by surgery, followed by adjuvant chemotherapy, or chemoradiation therapy followed by surgery, followed by adjuvant chemotherapy. And if you look at the results of the trial, the local recurrence rate appeared to be a bit higher in the short treatment, even though it was not statistically significant. On subset analysis, what they noticed that if you have low-lying rectal cancer, then the local recurrence rate was significantly higher with the short course, suggesting that there is the importance of downsizing, which is you don't get with short course of treatment. There was no difference in overall survival, and the grade 3 complications were comparable. The criticism of the study was it was not powered for the equivalence, and the data which shows no difference or a difference favoring long course is hard to interpret, and we need longer follow-up. So in summary, the standard of care for locally advanced rectal cancer is neoadjuvant chemoradiation therapy with 5FU plus 50.4 Gray radiation therapy. Nowadays, instead of 5FU, one can use oral capecitabine. People have done randomized trial comparing 5FU plus oxaliplatinum with radiation therapy, but the studies have not shown no difference in outcome and more acute toxicity. So the standard of care is chemoradiation therapy with 5FU or 5FU analog of capecitabine with radiation, followed by TME surgery. And when we do radiation therapy treatment, the terminology which we use is CTV. So we include the entire rectum, presacral nodes, internal iliac nodes, and the low common iliac nodes, and tumor with a margin with the mesorectum. So basically, we take the PTV1 to 45 Gray to 25 fraction, and this volume with the margin is taken to 50.4 Gray and 28 fraction. And this is how the beam arrangement looks like. Patient is in prone position, CT simulation, prone to remove the small intestine outside the treatment volume. Most commonly 3-field technique, 2 lateral and 1 posterior field. And this is how the portal looks like for the 3D conformed radiation therapy. This way you can reduce the dose of critical organs and still cover the target adequately to improve the tolerance and improve the outcome and response rate. Thank you.
I think what we're going to do is maybe we should change to the coffee break relatively because we've been behind because of the lights being up. And then we can continue the discussion later on since the coffees are available, I think. Yeah. So we might as well, instead of taking 15 minutes, we should do it like 5 minutes break since we're behind. I guess we should just go ahead and start, and I'm still finding that there are still people lining up. My next topic will be on adjuvant treatment of colorectal cancer. As you know, when we talk about adjuvant colorectal cancer, giving adjuvant therapy for colorectal cancer, we basically are talking about stage 2 and 3. As you know, stage 1 has a good prognosis, and stage 4 is already metastatic. So if you look at the survival curve, you find that stage 1 has a very good survival, but at the same time, if you look at stage 3C, it has a very dismal survival at 25%. Naturally, we have to figure out who should be getting adjuvant therapy. So we consider patients with high-risk stage 2 and stage 3 to be getting adjuvant therapy. The low-risk stage 2, however, has been controversial. I can discuss that later on. So what constitute high-risk stage 2? Those are the people with fully differentiated histology, lymphatic tumor that has lymphatic invasion or vascular invasion, and it's with the bowel obstruction, and also have perineural invasion, localized perforation, and if the margin is positive. Now, I didn't mention the lymph nodes earlier. We have to have removed at least 12 lymph nodes removed. That to say that it is adequately removed and resected out. In Europe, I think they consider 10 lymph nodes as the criteria. The reason why we say that we need to look at the number of lymph node removed is there's one study that says like if you remove 1 to 10 lymph nodes only, you have 67% 5-year survival, and also 56% almost what you call 8-year survival. But if you remove more than 4 lymph nodes, you have almost like 90% 5-year survival just by removing the lymph node. Nobody really exactly know the mechanism. Some think that this is basically allow us to do better staging, evaluation, and define better treatment.